Good day, Professor Falk. Thank you very much for visiting us again in Japan. I believe you're well rested today.
I am. Better than the other days.
Better than the other days, right? This is not your first time on the podcast, so welcome again also to the podcast. And I think I introduced you last time, but there's a change since last time. You moved universities, right?
Yes.
Yeah, you're now in Munich, right?
Yes.
You're the head of the Department of Conservative and Periodontal.
Yes.
Periodontology, right?
Mm-hmm.
Yeah. You also have so many other things that you're doing, with the Journal of Dental Research and with the FDI. So, introductions aside, today I would like to talk to you about the subject of deep caries management, since we heard the lecture about it. First of all, why were you interested in this kind of topic? Like, why do you concentrate on this kind of field?
Well, when I started my academic career about 15 years ago, that was one of the topics which came to me as very interesting, because when I learned about caries tissue removal during my studies, clinical studies in the university, it was very clear. You need to remove all the caries tissue or you would probably be banned or killed or whatsoever. Yeah. And when I started some years later at the university, after doing 4 years in a clinical practice, I read about this now being challenged and people coming up and say, well, we don't need to do this any longer. Particularly in deep caries lesions, we need to critically think about our traditional approach. And for me, it was very clear that this would be really a big change in dentistry. And I focused for nearly 10 years on that issue. It was the topic of my PhD. We did a lot of studies on that, in vitro clinical studies, systematic reviews, and so on. And at the end, also a lot of consensus papers where we really tried to push the community to embrace this new approach, this more biologically driven approach of managing particularly deep caries lesion. And if you look at the current curricula and how people worldwide are teaching that, I think we've been pretty successful. And it wasn't just me, it was a lot of other people. But by now, the approach which 10 years ago or 15 years ago, as I said, when I started was, well, I wouldn't say unthinkable, but still new, that you say we leave caries tissue behind.
Yeah, it's kind of out there.
And that is now standard. People are doing this. The guidelines are accepting it in many countries, and I think we have at least reached a point where you're not stoned any longer by when you say this, but people say, okay, this is something we can debate.
Yes, and I think for clinicians specifically, that are worried about patients being upset with them if they have, recurrent caries or recurrent pain, I think that's a very big thing that they would think about when they hear, these kinds of, ideas, let's say. Well, they're not ideas, you already have data proving that they work, right? I prepared a few questions over here, and since we're talking about caries and deep caries, glass ionomer are one of the materials that you use in restorations of these, and are mainly being introduced as a replacement to amalgam. Mm-hmm. Why is amalgam being replaced, since so many countries so far are still using it, and I don't think many clinicians are cost speaking, they think that amalgam is still a very good material to work with, for example. But why are we replacing it?
Well, it is a good material to work with. Yeah. First of all, because it's easy and it's resistant, and we can place it in difficult conditions.
Lasts forever.
It lasts very long, especially in high-risk cases, because it's antibacterial as well. So it is a good material. But we are not getting rid of it because it's not a good material, and also not because it's toxic in our mouth. This is what is important to explain to patients. We are getting rid of it because it contains mercury, and because of the Minamata Agreement, which... this was a city in Japan where a lot of people were poisoned due to mercury in an industrial factory. So it didn't have anything to do with dentistry. But based on that, a lot of countries in the world decided to phase it down at least, so to reduce the use of amalgam. And by now, a number of countries, Japan, but also Norway, so whole of Scandinavia, and since this year also the European Union now said, we are phasing it out. So it's gone. You can't use it except for very few exceptions in the European Union, for instance, is any longer. And I think the number of countries where you will be able to use it is getting smaller and smaller. So my prediction is it will be gone in 5 years, nearly all over the world, because at some point it doesn't make sense to produce it any longer because there are only very few people using it. So it will be absolute niche material. And that's why we are talking about the replacement materials. And that's not easy, because as an amalgam replacement, we need a material which is also easy to place, cost effective. It can be placed in the public insurance where you don't want to spend 200 or 300 euros per filling. So we need something which works and nevertheless fulfills all these requirements which amalgam fulfilled.
And in your opinion, is glass ionomer doing this? Is it like a good replacement material so far?
I think the glass-based materials, maybe wouldn't call necessarily them glass ionomers, but maybe the glass hybrids, so maybe, the more recent version of or evolution of the glass-based materials, they are one answer to the question. They're not the only answer, and they don't work for all the indications, as we know. So there are certain restrictions when it comes to large cavities, cavities with cusps and so on. But on the other hand, they do stuff which we probably wouldn't do with, let's say, composites, which they can replace cusps, but I can't use them in a high-risk patient, and I can't use them if moisture control is an issue, and I also can't use them if someone says I can't afford the XYZ euros for a composite. And in that case, I think for all these indications, the latest versions are a good alternative to amalgam, yes.
Let's see. When we were talking about like amalgams and glass ionomers, like, deep caries, or like when you're trying to replace an amalgam, for example, sometimes you find some marginal caries, or sometimes like deep caries inside. So decision making in making these restorations and how to deal with these cases, in your opinion, how can general dentists, and obviously if you're talking about specialists, it's a different story, they have a great experience in dealing with these cases, but for general dentists out there, what is the thought process that they need to go through in order to deal with these deep caries?
Well, I think there are two factors, especially when you say deep caries and maybe previous amalgam restorations.
Yeah.
The first factor is the way we can restore the cavity at all. Is this a cavity we can still restore with a direct restoration? Because if we are facing at many of these very extended amalgams, they were heavily undermining. We have very thin outer cavity walls. So in some cases, it should be a better option to go with an indirect, a ceramic restoration whatsoever, where you have cusp replacement and by cusp capping also stabilization of the teeth, than doing another round of direct restorations with a high risk of fractures. Because this is what we see in these teeth, that sometimes they fracture in a way which is very unfavorable, and it would have been better to be a bit more invasive early on, but thereby restoring and conserving the whole tooth. This is one element. The other element is the condition of the pulp. And I think that's where your question is going. This is what we need to assess. Is this a tooth where the pulp is still vital? Can we maintain vitality? Is it free of symptoms if it's vital, or does it have severe symptoms of rather irreversible pulpitis? So these factors should guide us. And when we say, okay, there's a vital pulp and the pulp vitality can be maintained, then certainly for the general practitioner, selective caries tissue removal is the way to go. So cleaning up the periphery of the tooth, 80% of the tooth, to maintain restoration longevity, but maybe leaving some carious tissue based on the logic of selective caries tissue removal near to the pulp to avoid pulp exposure, and then restore it with, as I said, either a glass ionomer, a glass hybrid, a composite, or indirect. That doesn't really matter then for the pulp any longer. Once I did the right excavation strategy and managing the pulp, then I can do whatever restoration I want to do based on the configuration of the cavity, as said before.
And about excavation, strategies. Simply put, like, I remember even when I was a dental student, like they told us, look for leathery feeling, and you can leave the remaining over there. How do you define it? Like, how can you help, people listening or watching us?
Yeah.
Define like, okay, this is okay to leave.
It's hard. It's hard. It needs training. It needs experience. It would be wrong if I say I can describe it in a way that everybody who's never seen a carious tooth understands it. That's not true.
That's not.
So you need some clinical experience. We tried in one of our consensus papers to describe the resistance the tissue gives you with a hand excavator against excavation. So when you say it's hard, I need to really press forcefully to remove anything, that's probably already firm or hard dentin, which you should leave on the outer side of the cavity. Leathery is a dentin which you can, without a big force, removed with an excavator in a spooning way. And this is also the second part of the description. If you use any kind of spooning instruments like an excavator or mainly a rosehead burr, for me, leathery is when I get these large, moist flakes. This is still leathery dentin. If you see that the flakes are starting to get smaller and are starting to be more dusty, this is not leathery any longer. This is already hard dentin. So you're basically in an area where you can probably stop excavation.
I see. Today in the lecture, you introduced a few ways that I personally thought that we were still working with, but for example, the dyes, dental detector dyes. It was very interesting for me. I did not really think of it, is that you do actually a lot more excavation once you're using these dyes, right? How do you recommend, approaching this when you're using these tools to identify whether there are remaining caries and how much you should leave inside?
So as I said in the lecture, I think there are a number of tools, but not all of them are suitable because some of them are basically providing us with information which leads to the wrong result. At the end, this is the key question. Does any of these tools help our patients? Does any of these tools lead to better outcomes? And the caries detector dye, it gives you as a dentist, or me as a dentist, a good feeling because we can say, oh, we removed all the red stuff. Yeah. But that's fully irrelevant for the patient. He doesn't care about the red stuff. He cares about the survival of his tooth and if he has pain or not. And there we know, as you say, the detector leads to massive over-excavation. It leads to much more pulp exposures. And hence, we, for example, in Munich, we've banned it. We don't use it any longer, as I also said in the lecture. There are alternatives, like, for example, polymer burrs, which give you some kind of objectivity because they're self-limiting, which you can use for excavation. And as I said, an experienced dentist with training, they will understand after some kind of calibration what is meant with leathery dentin, with firm or hard dentin. And then you don't need these tools any longer.
Yeah, experience is a thing that, and there are, like, especially for dentistry, it's a heavily experience-based, right? Like, you obviously have to follow the evidence and, the practices, but still, like, within these kinds of decisions, like, experience takes a major part of decision-making, right? About preserving the tooth, and you also refer to this in the lecture, like, there are evidence that, bacteria remain in the tooth, even when you leave some of the dentin, and it becomes basically the bacteria are isolated from the outer environment. And you said, like, there are papers basically mentioning that this is a fact, and that's why some dentists rather go that route. In your opinion, what's the best route to do to help the patients keep their teeth?
Well, at the end, what is very important, maybe also to understand how research works for the practitioners out there. In many cases, we researchers, we need to look for outcomes which we can measure in short term. And histology is one of these outcomes. I can cut teeth and I can see there's inflammation, there's bacteria, whatsoever. The question now is, and that's where, from my point of view, the argument with the bacteria is falling flat. This is not a clinical outcome. Having bacteria in a tooth after selective removal is very expectable. Yes, I leave them, I seal them actively, and thereby I hope that I contain them and they don't do any harm any longer. So I would expect them to be there. It would be a wonder if they wouldn't be there any longer. And secondly, and more importantly, the question is not if there are bacteria. The question is, does this lead to any worse or better outcomes for the patient? Does this intervention work clinically? Because I'm a clinician. I'm not a histological expert, but I'm a clinician. I treat patients. So what I look at is not the histology, it's the clinical outcomes. And there it's very clear. Yes, there may be bacteria left. And yes, maybe there's even a chronic inflammation in the pulp in some instances. But the clinical evidence over 3, 5, 10 years of follow-up, we have 10 years follow-up studies, they clearly say leaving bacteria, selectively removing the caries dentin in deep lesions with vital pulps leads to better results. So there's not a single study at the moment saying that the results are worse when you do selective removal over the complete or non-selective removal. So that's, for me as a clinician, far more important than the histological argument, to be honest, because that there might be chronic inflammation. That also applies to any kind of root canal treatment. If you look in the histology, you will always have chronic inflammation around the gutta perca at the root canal treatment. But nevertheless, this also works. We are seeing good results if we do root canal treatment right, and the same applies to the selective removal.
I see. And the presence of, and I thought that if you seal the bacteria completely, that it dies off. But apparently it remains, even like even though it's completely isolated from the outside.
Well, you can still stain them. They remain there.
Yeah.
But they don't
They're inactive.
necessarily, yes, exactly, they don't dissolve and fully, especially after the few weeks in these studies. They did the clinical therapy, and then few weeks later they extracted the teeth and they stained the bacteria. Of course they are still bacteria, because why wouldn't they? Where should they go? In the long run, it might well be that you have some dissolution processes and at some point you can't stain them any longer, but especially after that short-term period, yes, they are still there and they are stainable.
Detecting the caries and trying to make sure that which part to leave and which part to go is, like you said, like there are many tools, and experience has to help us identify which parts to leave. But now AI tools are there, and you're a very big expert in this field. How is AI helping us kind of decide on where to proceed when it comes to this matter?
Well, I think we are just at the very beginning with that. At the moment, we have a lot of AI studies and maybe also some tools, although there are far fewer clinically usable tools than studies in the field, because it's hard to implement them clinically. And they are mainly focused on detection. So they are focused on, I can find caries lesion on a bite wing, or I can find MRH on a photo. When it comes to what you're alluring to, the clinical decision aid, an AI which tells me, oh, there's a high risk that this will happen, rather go down this route, that's very, very rare. What we have is, and I showed this in my lecture today, we have some studies showing, for instances, that based on an image of a deep caries lesion on a radiograph, and maybe some info on top, like how old is the patient and what kind of symptoms he or she had, that AI can predict the risk of pulpal complications like pulp exposure. That's possible, but this is a very small data set. It's from one center in Denmark, for instance, the data I showed you. So I wouldn't say we are there yet, but in the long run, I'm very certain that with more and more data, we will have AI tools which tell us this tooth will probably need root canal treatment because the lesion is too deep. With that symptom complex, and in this patients with previous experiences, you should do this and this and this. Here, you can't do only non-surgical perio treatment. You need to consider that in the second step, surgical perio treatment is needed. So we will have AI supporting us in a lot of decisions in the future.
Yeah, especially for decision making, where pulp, like a little bit of an invasive therapy is included, like partial pulpotomy or pulpotomy in general, is a big decision for dentists, and not many of the dentists were trained on that. I know I wasn't. I practiced, and that's how I learned how to treat patients like that. But not everyone is able to do that. How do you recommend people to, approach these cases, and especially, cases that might need pulpotomy, for example, or like you can see that, it's better to remove the caries in this case and excavate, a little bit of the pulp tissue?
Well, at the end, there are several elements to this. Of course, first of all, there should be some kind of training, which is very hard. The clinical training in these cases is like a traumatology training. It's very hard to train dentists in dental traumatology clinically, because these cases usually occur in emergency settings, so during the night when there are no students there. Even if there are students there, it's stressful, even for the operator himself, because it's a child, there's pain, there's blood, the mother is in tears. So it's not a situation where you can easily say, oh no, dear student, come and watch and learn. So it's not a good learning environment, and that's also true for these settings. So I think what people can do, that would be one advice, if they're dealing with a case where they want to do a root canal treatment. Why not actively understand a bit better and assess a bit better what I'm doing until I remove the pulp? Because what are we doing? We are doing a trepanation, so we're opening up the pulp, and then we are facing it. And then there would be an option to see and to understand, okay, this is how it looks. I try some hemostasis. It really stops bleeding or not. So in these cases where it doesn't really matter if I make a mistake at the coronal pulp because I want to remove it anywhere, then I can already learn a bit about the behavior and the texture of the pulp and so on. And if I really have a direct pulp capping in the next month, then I think just as you say, just try it out. Be a bit bold. If you have rubber dam and if you have some magnification, taking a sterile burr and removing 2 millimeters of the pulp orifice or the entry I've made there, the exposure, that's something which most dentists will manage. And then it bleeds, okay, and then I need to stay calm, and I know, okay, I can manage the bleeding with saline or with sodium hypochlorite. Of course, I need to be prepared. I need to have a capping material in place so that once I'm finished, I can do something for it. So the whole procedure needs some consideration up front, but it's not rocket science once you do it. I would start with the easy cases, the partial pulpotomies, in maybe a tooth where I have good visibility and where everything like moisture control works well, but then just try it out.
Last question, and this is just basically going over everything that we've talked about, is how do you see the development of this field happening, and what are the changes that, for example, AI technology have taken over the past year, for example? I mean, since we talked, it's almost a year that passed. Were there any big changes that affect the dental field in this, time period?
Well, I think the AI development we saw in the general world was faster than in the medical world, which is normal because of regulatory challenges, slowing down any kind of implementation, as I hinted at before. What I see, however, is there's a massive evolvement of tools in the assistant field in dentistry. So we have the telephone assistant, we have the documentation assistant, lots of things where patients can interact with AI tools for the practice so that we relieve basically assistant stuff. It's not so much the dentist necessarily today being relieved. We have these detection tools, which I mentioned before. But what we also saw is that there is something on the horizon which will have a big impact on the dentist itself, like, for example, robotics. There is now the first dental robot which does cavity preparation and crown preparations. It's still in its infancies, but they have a lot of money, that company there, and we see at the horizon that these kind of things will also impact on dentistry itself, on the mechanical thing of dentistry, and I think that is, for me, the biggest change since the last year.
I talked to Professor James Choi. I don't know if you probably know him. Yeah. And he said, like, in China, they're already kind of having these kinds of robots that are able to do kind of implant treatments.
For implants, that's already a while. I think this is now 6 or 7 years ago, the first autonomous implant robot. But
isn't that scary?
It is scary, but well, it's reality. And I mean, China has just started with a robot hospital where the doctors are robots. So you go in there, and the robot has a big large language model in the background, which, like ChatGPT but smarter, can at least triage you. Interestingly enough, the nurses are still human, so it's just the robots. But because they are facing such a pressure on the healthcare system with I don't know how many billion people now, that's the way they go. And is it scary? Yes, to some degree it is. A lot of these new developments have fantastic elements, but also scary elements.
Well, future looks bright, I guess. Thank you very much, Professor.
Thanks for having me.
Appreciate you.
Thank you.